Hello, this is a video lesson on the procedures for the lower extremities continued part B. We're going to start off with the lower leg, looking at projections of the AP and lateral, first of all, the lower leg. We're going to recommend that we perform them at 48-inch SID to reduce divergence of the X-ray beam and so that more of the body part is included. Both of these projections are performed tabletop. For the AP projection, the patient is either supine or seated. We're going to adjust the patient's body parts so this pelvis is not rotated. And we're going to adjust the legs so the femoral condyles are parallel with the image receptor. The foot must be flexed until it is in the vertical position. The central ray is going to be perpendicular to the center of the lower leg. And we're going to have collimation 1 inch on the sides and 1.5 inches beyond the ankle and the knee joints. The structures shown include the tibia, the fibula, and the adjacent joints. For the evaluation criteria, we want to make sure we have the ankle and the knee joints on one or more images. We want the entire leg without rotation, and that's where the proximal and distal articulations of the tibia and fibula are moderately overlapped, but the midshaft of the fibula should be completely free of superimposition from the tibia. On the lateral projection, we're going to perform a mediolateral projection unless we have a patient we need a cross-tibia lateral. Our patient is supine. We're going to turn the patient toward the affected side with the leg on the image receptor. We're going to adjust the rotation so that the patella is perpendicular to the image receptor, and to ensure that a line is drawn to the femoral condyles is also perpendicular. The knee must be flexed to ensure a true lateral projection. Our central ray is going to be perpendicular to the midpoint of the leg. Collimation must be 1 inch on the sides and 1.5 inches beyond the ankle and the knee joints, and it's the same structure shown as we have with the AP projection as well. So the evaluation criteria is that we want the ankle and the knee joints on one or more images. The entire leg should be in the true lateral projection, and how that is demonstrated is with the distal fibula is superimposed by the posterior half of the distal tibia. We want slight overlap at the tibia on the proximal fibular head, and there must be moderate separation of the tibia and fibular bodies or shafts except at their articular ends. We're going to possibly have reduced superimposition of the femoral condyles because of divergence of the X-ray beam. Now the knee, there are numerous projections we're going to look at, but we're going to start off with the AP projection and continue from there. So with the central ray angles for the AP and the AP oblique projections, we're going to make sure that if our patient, their ASIS, the tabletop distance, measures less than 19 centimeters, then we're going to angle 3 to 5 degrees caudad, and that would be for the thin pelvis. If the patient's ASIS, the tabletop distance, measures 19 to 24 centimeters, we're not going to angle at all. And then if the patient measures the ASIS to tabletop distance measures 24, greater than 24 centimeters, we're going to angle 3 to 5 degrees cephalad, and that's for the large pelvis or for the large buttocks. So for the AP projection, we're going to have the patient supine with no rotation of the pelvis. We're going to have the image receptor under the patient's knee and flex the joint slightly to locate the apex of the patella. As the patient extends the knee, we're going to center the image receptor about 1/2 inch below the patellar apex, and this centers the image receptor to the joint space. We want to adjust the patient's leg by placing the femoral epicondyles parallel with the image receptor. The patella does lie slightly off-center to the medially. So we're going to again direct the central ray 1/2 inch inferior to the patellar apex. Our collimation is going to be an 8x10 and going to adjust down to 1 inch beyond the sides, and we're going to get an AP projection of the knee structures. On the image, we want the knee fully extended if the patient's condition warrants or permits that to be done. We want the entire knee without rotation. That means that the femoral condyle should be symmetric and the tibial intercondylar eminence should be centered. There should be slight superimposition of the fibular head if the tibia is normal, and the patella is completely superimposed on the femur. There should be an open femoral tibial joint space with interspaces of equal widths on both sides if the knee is normal, and that provides us with the AP projection of the knee. On the AP projection for the weight-bearing method, the purpose is to look for narrowing of the joint spaces of one or both knees. So the patient's going to be upright with the back against the vertical grid device. We're going to adjust the patient position to center to the knees to the image receptor. We want the toes straight ahead with the feet separated enough for good balance. Ask the patient to stand with the knees fully extended and weight equally distributed on their feet. We want to center between the two knees at a location of a level 1.5 inch below the apices of the patella. The beam should be horizontal and perpendicular to a point, as we already said, 1/2 inch below the apices of the patella in the center between the two knees. The collimation should be 14 by 17 and 1 inch beyond the sides. So the structures shown are the joint spaces of the knees plus varus and valgus deformities can be evaluated. So we're looking here at both knees without rotation. We want the knee joint spaces centered to the exposure area. On the lateral projection, which we commonly do the medial-lateral unless we do a cross-tibal lateral, we're going to turn the patient on their affected side and ensure their pelvis is not rotated. We want to have the patient bring their affected knee forward and extend the other extremity behind it. The other extremity must be placed in front of the affected knee. We want to flex the knee 20 to 30 degrees to relax the muscles, and that allows you to show the maximum volume of joint cavity. We want to prevent fragment separation in new or unhealed patellar fractures. The knee should not be flexed more than 10 degrees. The epicondyles should be adjusted so that they are perpendicular to the IR, and the patella is perpendicular to the plane of the image receptor. The central ray is directed to the knee joint 1 inch distal to the medial epicondyle at an angle of 5 to 7 degrees cephalad, and that is because the distal condyle is 5 to 7 degrees more distal than the lateral. We're going to collimate down to an 8 by 10 and have 1 inch beyond the shadows on each side. And we're going to see a lateral projection of the distal end of the femur, the patella, the knee joint, the proximal ends of the tibia and fibula, and the adjacent soft tissue. Looking at our image, we want the knee flexed 20 to 30 degrees, and that's demonstrated by the femoral condyles being superimposed. There are some things that we need to know about rotation and as well as the angulation of our tube. The anterior surface of the medial condyle will be closer to the patella if it has over-rotation toward the image receptor, meaning that the medial condyle is in the patella. If the medial condyle is away from the patella, then that means it was under-rotated. If we have the inferior surface of the medial condyle in the medial condyle is caudal, which is down in the femoral tibial space, that means we don't have enough cephalad angulation. And if the inferior surface of the lateral condyle is caudal to medial one, that means there's too much cephalic angulation. So the fibular head and the tibia are slightly superimposed. Over rotation causes less superimposition, and under rotation causes more superimposition. We want the patella in a lateral profile, and we want to see the open patellofemoral space, which can be seen here. We want an open space between the femoral condyles as well as in the tibia too. On the AP oblique lateral rotation, we're going to have the patient supine and support the ankles. We want to elevate the hip of the unaffected leg enough to rotate the affected extremity. We want to support the elevated hip and knee of the unaffected leg and center 1/2 inches below the apex of the patella. We want to rotate the extremity 45 degrees laterally. So we're going to, again, be centered 1/2 inch inferior to the patellar apex, and our collimation is going to be the same as it was for the AP and the lateral. This time we're going to see an AP oblique of the laterally rotated femoral condyles, the patella, the tibial condyles, and the head of the fibula. What's going to be shown are the medial femoral and tibial condyles. So we have moved the patella out of the way, and we're looking at the medial side of the knee. We can see the tibial plateaus, and we can see the fibula is superimposed over the lateral half of the tibia. So that is properly positioned. And we want to see an open knee joint. On the medial oblique, we're going to do the same thing as the lateral, except we're going to medially rotate the extremity 45 degrees. We're going to center to the same location, and we're going to have the same collimation. This time we're going to have a medially rotated femoral condyles, patella, tibial condyles, proximal tibiofibular joint, and the head of the fibula. So our important thing is we want to see the tibia and fibula separated at their proximal articulation. So we should see an open tibiofibular articulation. We should see the posterior tibia, and we should also definitely see the lateral condyles, both the femoral and the tibial condyles, because we've moved the patella medially. On the PA axial projection, which is for the intercondyloid fossa Holmblad method, we've got 3 different ways that we can do so. We can have the patient standing with the knee in a stool, or the knee flexing in contact with the image receptor in some other way, or even kneeling on the x-ray table. The most common one is the second one, with them standing up against the image receptor, against the upright bucky. So we're going to place the image receptor against the anterior knee. We're going to center to the image receptor to the apex of the patella. The knee should be flexed 70 degrees from full extension. Very important, we want to be perpendicular to the lower leg, entering the superior aspect of the popliteal fossa and exiting at the level of the patellar apex. We're going to collimate to an 8 by 10, and we want to adjust down to 1 inches beyond the sides. We're looking at the intercondylar fossa and the posterior inferior articular surfaces of the condyles of the femur, as well as the medial and lateral intercondylar tubercles of the intercondylar eminence and the tibial plateaus in profile. The big thing is the intercondyloid fossa. So here's an image of the Holmblad method showing that 70-degree angulation of the flexion of the legs. We're going to see that the beam is perpendicular to the lower leg. It's going to be seen as well. The second method we can do for which we can perform the intercondyloid fossa is the Camp Coventry method. Our patient is prone with the knee flexed and not rotated. They're going to flex their knee either 40 or 50 degrees. We'll look at the difference in a moment. We're going to center the upper half of the image receptor to the knee joint, and we're going to centroid going to project the joint into the center of the image receptor. We want to adjust the legs so that the knee has no medial or lateral rotation. So the centroid is going to be perpendicular to the long axis of the lower leg as it was in the previous image. So we're going to be perpendicular to the lower leg. If we angle the X-ray tube 40 degrees caudad, the knee is going to be flexed 40 degrees, and we're going to angle the beam 50 degrees when the knee is flexed 50 degrees. So this is just showing the 40 with the 40. We're going to show the intercondyloid fossa again with all the other structures that we just saw on the Holmblad method as well. And that's exactly what we're looking at. Here's the Coventry showing the 40-degree flexion of the leg and then the 40-degree caudad angulation of the tube. So both the Holmblad and the Camp Coventry methods have the same demonstration or evaluation criteria. The goal is to see the open intercondyloid fossa. We want to see the posterior, inferior, inferior surface of the femoral condyles. The knee joint space should be open, and we want to see the tubercles, which is the eminence is going to be shown. Apex the patella should not be superimposing the fossa, so it should be well up here, well out of the way. Another option is the AP axial projection for the intercondyloid fossa, Beclaire method. With this one, we're going to have the patient supine. So it's an AP axial projection. We're going to flex the knee to approximately 60 degrees, the long axis of the tibia. We're going to support the knee on sandbags, which can be shown here, and we're going to place the image receptor under the knee. We're going to adjust that the femoral condyles are equidistant from the image receptor. We're going to center perpendicular to the long axis of the lower leg, entering 1/2 inch below the patellar apex. The collimation is the same. It's an 8 by 10, 1 inches on the side, and we're going to see the intercondyloid fossa, the intercondylar eminence, and the knee joint. In the Baclair method, we're looking at the evidence of the proper collimation and the presence of a side marker. The key is the open intercondylar fossa. We want to see posterior inferior surface of the femoral condyles, intercondylar eminence in the knee joint space. We want no superimposition of the fossa by the apex of the patella, and we want no overlap. So this is called the Baclair method. In this particular method, just as we saw the other two, we're going to ensure that the beam is perpendicular to the lower leg. Now there are three projections that the patella we'll take a look at. There's the PA projection, the tangential, and then which is the merchant, and then the tangential projection Sedigas method. So taking a look at the PA projection, the patient is prone. They're going to center the image receptor to the patella, and we're going to make sure the patella is placed parallel with the plane of the image receptor. We're going to rotate the heel about 5 to 10 degrees laterally. We want to have the central ray perpendicular to the mid-popliteal area exiting the patella, and we're to collimate down to a 6 by 6. The improvement of this for the patella is that we're going to have a shorter OID, and that's compared with performing an AP projection. So this is what's recommended for a patella. And so now we can see a vertical fracture, by the way, of the patella in this patient, but we're able to see the patella is much closer to the image receptor and get higher spatial resolution and less magnification also. The patella should be completely superimposed by the femur. On the tangential projection merchant method, we have to have a special board. There has to be an image receptor holding device plus a board in which you're going to place your patient, called the merchant board. So we're going to elevate the knees approximately 2 inches to place the femora parallel with the tabletop. Adjust the angle of the knee flexion to 40 degrees. It can vary between 30 and 90 degrees. But they're showing the 40 degrees shown here. We're going to strap the legs in, as we can see, to control calf motion, to calf level to control leg rotation and have the patient relax. We're going to place the image receptor perpendicular to the central ray and resting on the patient's shins. So looking at this, we're going to be perpendicular to the image receptor. With a 40-degree flexion, we're going to angle the central ray 30 degrees caudad from the horizontal to achieve a 30-degree central ray to femur angle. We're going to enter midway between the patella at the level of the patellofemoral joint. Our collimation is 2 inches above the patellar shadow and 1 inch on the sides. Our SID should be 72 inches for this image. And we're to see a bilateral tangential projection that shows axial images of the patella and the patellofemoral joints. And this is an image showing with the patient in the merchant method. We're going to see the patella in profile. We've got the femoral condyles, the intercondylar sulcus. The open patellofemoral articulations are important here too. And we can see the bony detail. The last projection of the patella is another tangential projection, which is the most common one, and that's the Sedigas method. Now this is also called the sunrise or the skyline view, more commonly the sunrise. And there's 4 different ways to position. These 2 on this slide are the most common, but this should not be attempted until a transverse fracture of the patella has been ruled out with the lateral image or the patient is in pain. We can have the patient supine or prone. Prone will allow the knee to be flexed to a greater angle, as can be shown on this image or picture. But we want to flex the knee until the patella is perpendicular to the image receptor if the patient's condition permits. With even slow flexion, the patient should be able to tolerate the position. We want to center the joint space between the patella and the femoral condyles. In this case, we're going to angle 15 to 20 degrees cephalad. So looking at the collimation is the 4x4, and we're going to be looking at articulating surfaces of the patellofemoral joint space, and vertical fractures will be shown. Another method is to have the patient supine, and that is with them holding the image receptor, and we're still going to make sure that we're perpendicular to the joint space between the patella and the femoral condyles. Alternatively, you can have the patient with the patient seated, or you can have them with them lateral. So these are different options we have for the set-a-guess method. In the set-a-guess method, you want the patella in profile. The femoral condyles and the intercondylar sulcus should be visualized. And the big thing is we want to see the patellofemoral articulation. And here's a patient with the bilateral patella examination using the set-a-guess method. On the femur, we're going to perform two projections, the AP and the lateral. On the femur, we have the AP projection, which we're going to do perform supine. We want to check the pelvis to make sure it's not rotated by checking the ASIS to tabletop distance bilaterally. We want to make sure that we center the affected thigh to the midline of the image receptor. When the patient is too tall to include the entire femur, we will include it on a single image, the joint closest to the area of interest. Now for the proximal femur, you want the top of the image receptor at the level of the ASIS. Rotate the extremity internally 10 to 15 degrees to place the femoral neck in profile. On the distal femur, which is the one that's shown down below, we're going to internally rotate the leg to make sure it's in a true anatomic position. We're going to ensure that the epicondyles are now parallel with the image receptor and place the bottom of the image receptor 2 inches below the knee joint. With these two images, we're going to direct the beam perpendicular to the mid-femur and the center of the image receptor. We want collimation 1 inches of the size of the thigh shadow and 17 inches in length. We're going to have AP projections to the femur, including the hip and or the knee joint or both. And due to the length of the femur, that is why we many times have to perform two exposures, one of the proximal femur and one of the distal. And so here's the two images, one of the proximal, one of the distal femur, and the AP projections. The information here that one of the key things we want to make sure is that most of the femur and the joint nearest to the pathologic condition or the site of injury is recommended. The femoral neck should not be foreshortened on the proximal femur. The lesser trochanter should not be seen beyond the medial border of the femur, or a very small portion can be seen. There should be no knee rotation on the distal femur. An idiorthopedic extremity should be seen in its entirety. On the lateral projection, we're going to perform a mediolateral unless contraindicated. We're going to ask the patient to turn on the affected side. We're going to have the body positioned so that it's centered affected thigh to the midline of the grid. We're going to do the same thing we did for the AP. We're going to place the top of the image receptor at the level of the ACEs for the proximal femur and adjust it so that we're adjusting the pelvis so it's rolled posteriorly 10 to 15 degrees from its lateral position. For the distal femur, we're going to draw the patient's uppermost extremity posteriorly and support it, or draw the upper extremity forward and support it at the hip level. So you have two ways to do this one. Two different methods, whichever one that's best for the patient. Flex the knee about 45 degrees, and we're going to adjust the body rotation to place the epicondyles perpendicular to the tabletop. We want to place the image receptor approximately 2 inches below the knee joint. We're going to be perpendicular to the mid-femur and it's centered to the image receptor. We're going to have 1 inch of collimation on the thigh shadow and 17 inches in length. We want the lateral projection for about 3/4 femur and the adjacent joint, and we'll use 2 image receptors to include the entire length of the adult femur. And here's the two images that we can see. We've got the um, lateral projections of the proximal and the distal femur. So the idea is that we're going to, again, get most of the femur, the joint close nearest to the pathologic condition or site of injury. A second radiograph of the other side of the femur is recommended. Any orthopedic appliance should be seen in its entirety. And then with the hip included, we want the opposite thigh not over the proximal femur and hip joint. The greater trochanter should be superimposed over the distal femoral neck, and the lesser trochanter is visualized on the medial aspect of the proximal femur. On the distal part of the femur, we're going with the knee included, we're going to see the superimposed anterior surface of the femoral condyles, the patella in profile, and see an open patellofemoral space. Long bone measurement is our last topic, and this is primarily used to determine limb length discrepancies. This occurs primarily in younger patients. It can be upper or lower extremities, but usually is lower. Imaging modalities can be radiography, CT, MR, or ultrasound. Radiation protection is definitely used since the patients can require yearly images, so gonadal shielding, careful positioning, secure mobilization, and close collimation are important. So taking a look at the images here, we're talking about putting the back against the vertical image receptor. We're going to adjust and immobilize the extremities for an AP projection. You want to separate the ankles 5 to 6 inches and place a ruler between the patient and the image receptor with the top of the pelvis and extending down between the legs. If it's a unilateral study, position the patient with the ruler behind each extremity. For localization of the joints, we're going to localize the hip joint by placing a mark 1 to 1.25 inches lateral-distally at a right angle to the midpoint of the ACIS and the pubic symphysis. For the knee joint, we're going to localize that by adjusting, just palpating 1/2 inch below or just below the apex patella at a depression between the femoral and the tibial condyles. And we're to locate the ankle joint midway between the malleoli. We're to take 3 separate exposures, moving the X-ray tube and the image receptor for each exposure. So the central ray is going to be perpendicular to the center of the image receptor. We're going to collimate 14 by 17 and within 1 inch of the shadow of the thigh, the lateral thighs. We're going to have a composite of 3 exposures that digitally stitch into one image, which includes all anatomy from the hip joints to the ankle joints. And so here's our 3 images that we're going to take of the hips, the knees, and the ankles with the ruler behind the patient. And so we see evidence of proper collimation, we see evidence of the special ruler, and then these images are digitally stitched together. And we're including both the hip, the knee, and the ankle joints. This concludes our video lesson on the lower extremity.